WJET TV 24 Erie.
The Erie County Medical Society presents Focus on Erie Medicine, the program that explores and explains the complexities of modern healthcare as it relates to you.
Good afternoon, ladies and gentlemen, and welcome to Focus on Erie Medicine. I'm your host for today, Dr. David Diedemann, and my guest is Vincent Rogers, MD. Vince and I grew up together and attended school all through college, and Vince went on to the University of Cincinnati and obtained his medical degree there in 1968. He's a graduate of the orthopedics program at Hammett, where he currently is chairman of the Division of Sports Medicine. And Vince has an enthusiasm for orthopedics the way that I do for dermatology, and I thought it would be a wonderful idea if he would share with us today some diseases of the shoulder and some new surgical techniques with the arthroscope. And we would like to begin our discussion today, Vince, and share with the audience maybe some of the common problems that we see with the shoulder.
Very good, Dave. Thanks for asking me to be here today. I brought along a model of a shoulder joint just so that I could demonstrate the anatomy of the shoulder and then talk about some of the common problems that we see with the shoulder, not only in sports but in everyday use of the shoulder. As you look at the front of the shoulder, the first thing that you see is the collarbone. And the collarbone actually at this point is the only place on the body that the bone of the upper extremity attaches to the bone of the skeleton. The reason for that is that the bone that we talk about being the wing bone, the scapula, really is just encased in muscle tissue and floats quite readily over the surface of the back. Everything rotating around this point where the collarbone attaches to the rest of the skeleton. The shoulder is an extremely mobile joint and consists of these two bones that I've mentioned, the collarbone and the wing bone. The two of them together forming a very nice socket of the ball and socket joint. The upper arm, this is called the humerus, the upper arm with the ball at the end sits into that socket. It allows a tremendous amount of motion. The motion that occurs within the shoulder joint is really twofold, and only 60% of the motion in the shoulder, as we think of it, comes out of the ball and socket joint. The other 40% of that motion comes from the movement of the collarbone and the wing bone on the chest wall. Common problems that occur in the shoulder joint and things that people think about every day are bursitis. Bursitis is a term that refers to an inflammation of the tissue between the ball and the socket. Any place in the body where there's a tremendous amount of motion, the body forms a fluid-filled sac called a bursa. That bursa sits right in this area. If that motion becomes inflamed or pinched in any way, the first thing that a patient notices is pain. They notice an inability to raise the arm. And then, because of this inflammation, soon that pain limits motion. It becomes very difficult then, say, as you develop bursitis, to reach for the can of coffee on the upper shelf. So you stop doing that, and you'll reach with the other hand. Doing that over a long enough period of time, pretty soon the shoulder just won't go up anymore. The terminology for that, in layman's terms, is frozen shoulder. So a person with bursitis, through lack of use due to the pain, will develop a frozen shoulder. That's one very common problem in the shoulder that is really, even though we call it bursitis, it's a whole myriad of problems about the shoulder joint. We have a set of muscles that come across the back of the joint, across the front of the joint, and over the top of the joint that perform this rotational movement. Those muscles are called the rotator cuff. That cuff of tissue causes all of the rotational movements of the arm. If I could stand for a minute and demonstrate some of the rotational movements. Probably easiest to do if I take off my coat.
Okay.
When the shoulder moves, and I mentioned that 60% of the motion occurs at the ball and socket joint. If I hold my shoulder down and lift, I can only lift to this point. I can't get up any higher. However, if I let my shoulder rotate up and get the other 40% of that motion, now as you see my shoulder going up, so does the ball and socket joint all the way up to the top. Rotation of the ball in the socket in this direction is just one function of the rotator cuff. Another function is to rotate it outwardly, and a third function is to rotate it inwardly. That combination then can be used in many ways. It can be used to lift the arm up to go into the cupboard, or in athletes it can be used to load up the arm and, as a pitcher would do, throw a ball. So that requires a tremendous working together of these muscles that we call the rotator cuff. Now, if the patient rotates the arm up and these tendons bump into the socket, this is called impingement. This pinching or impingement causes the bursitis.
Right.
Now, when we see this in an athlete, first thing we'll do is put them on an exercise program to calm down the inflammation. Physical therapy with ultrasound, heat, ice treatments will calm down the inflammation and allow the ball and socket to move without pain. The second thing to do after relieving the pain is get the patient to resume a full range of motion. We want to get rid of that stiffness. And thirdly, after those two things have been accomplished, the third thing is to regain the strength that was lost when the motion was lost.
Have to rebuild the muscles a little.
Have to rebuild the muscles.
Right.
So this is probably the most common thing that happens to the layperson who isn't involved in sports. It happens in the athlete who uses his arm in any overhead movement, such as throwing, serving a tennis ball, or the overhead motion of swimming. So swimming, throwing, and tennis are very common overhead motions that cause rotator cuff pain. So the treatment for them is exactly the same as the treatment for bursitis in the elderly patient, over 40, as myself. And every time I sleep with my arm up over my head, I wind up the next morning with a stiff shoulder because I've irritated the bursa, and it takes half an hour to get the shoulder loosened up so I can use it again. So this is a very common wear and tear problem that we see in all age groups that are interested in sports. Now, we'll discuss later in the show the arthroscopic treatment of this problem. A very common problem in athletes also is dislocation of the shoulder. The ball can pop out of the socket. The ball out of the socket. And that's caused by a rupture of this ligament. This is an injury that occurs in football, in skiing. When it occurs, it's extremely painful. The shoulder hangs in a very awkward manner, and it takes an anesthetic sometimes or a severe painkiller to relax the shoulder so that the ball can be popped back into the socket. Once again, the arthroscope has allowed us a means of repairing this problem.
Okay. It sounds very interesting, Vince. We have to just take a moment for a small commercial message, and we ask our audience please to rejoin us in just a few moments as we continue with our discussion of common problems of the shoulder and new arthroscopic surgical techniques. Welcome back, ladies and gentlemen, to our second half of Focus on Erie Medicine. I'm your host, Dr. David Diedemann, and my guest today is Dr. Vince Rogers, an orthopedic surgeon in practice here in Erie and chief of the Division of Sports Medicine at Hammett. And we've been discussing with Vince some of the common problems of the shoulder. And before the break, Vince, we got up to talking a little bit about separations and rotator cuff pains. And maybe we should just talk a little bit more about these common problems in the shoulder.
Very good. Actually, the thing that we spent most of the first part of the show on was, I think, probably the most common problem in the shoulder of all ages, and that's bursitis. Bursitis is the layman's term for this problem, and what I was going to say in the beginning was that that really is an inflammation of the tendons beneath the socket. Now, there's a bursa between the tendons and the socket, but it's an inflammation not only of the bursa itself, but of the 4 tendons that make up that rotator cuff that we were talking about. The tendinitis then can be treated with physical therapy like any other tendinitis. Any tendinitis in the body will respond to physical therapy that will stretch the tendon out and make it supple,
Right.
followed by strengthening it and making it strong. Most of the time, we don't develop tendinitis unless we have a weakened or fibrotic and shortened tendon. That's what develops tendinitis. If we lengthen it, make it flexible, and strengthen it, the tendinitis will disappear. And so that's the physical therapy treatment for this problem of bursitis or tendinitis of the shoulder. So the physical therapist will encourage range of motion exercises, and maybe you've heard people have to use a pulley system so that the good hand can pull the sore shoulder
Right.
up into the elevated position that it has trouble lifting itself up into. The physical therapist also will just gently take the shoulder and move it through the full range of motion that I demonstrated earlier. That range of motion is very interesting because the shoulder has to be able to rotate back in order to comb your hair. In order to scratch your back, you have to internally rotate the shoulder way behind your back.
Right.
And those are just motions that are immediately lost as soon as a patient has bursitis or tendinitis of the shoulder. So the physical therapist will help the patient regain that motion. Once the motion is back, the shoulder begins to function, but it needs strength now. And so dumbbells or pulleys will be used to strengthen the shoulder. That's the most common problem in the shoulder joint. The second, one other problem, other than the dislocation that we mentioned before, is shoulder separation. If you watch football on Sunday following this program, you notice that a quarterback will be thrown to the ground and the commentator will say, "You must have a separated shoulder." Landing on the shoulder, on the point of the shoulder to the ground, will cause the junction between the collarbone and the wing bone to separate. These two bones form together with our ligament to make up a part of the socket of the joint. If that ligament is sprained, the two bones can separate, and the collarbone will actually pop up above the other bone. You'll see that on the top of a shoulder in some people who have a lump on the top of their shoulder.
Right.
That shows that they've had a shoulder separation in the past. The treatment for that initially is ice it down, make sure you don't get a great deal of swelling, rest it in a sling. As soon as the pain's gone, then physical therapy to regain motion and strength. Surgery is not usually necessary for the problem of shoulder separation unless the separation is so bad that the collarbone flies way up in the air. And if it does that, then something surgical has to be done to hold it back in position. If it only partially separates, then we feel that the shoulder function isn't really limited enough to put the patient through a surgical procedure. So we've talked about dislocations, bursitis, separations of the shoulder, tendinitis. Everyone thinks about arthritis when they think about a joint. The joints that we develop arthritis in that need major surgery are the joints that we walk on, the ankle, the knee, the hip. The joints in our upper extremity do not develop arthritis to the extent that our hips and knees and ankles do, because we're not walking on them. They don't have the weight-bearing pressure. And so it's very uncommon to get actual arthritis, that is, bony changes in the shoulder caused by the bones rubbing together.
Right.
It does happen, but it's very uncommon, and it's usually associated with a previous injury, such as a fracture or a dislocation. When that happens, there is surgery available, total joint replacement surgery for the shoulder, but it's done less than 1% as commonly as hip and knee total joint replacement surgery is concerned. Now, we've talked a lot about the injuries and the diseases of the shoulder joint, the fact that a physical therapist can help all of these problems. Most of the surgery for the shoulder up until the last 5 years required a fairly large incision. The incisions were of two different types. One incision would be right over the front of the shoulder. That's a very standard incision. It goes between two of the muscle layers and allows many of the operations on the shoulder to be performed. The problem with shoulder incisions is that the incision is always placed opposite Langer's lines, which are the little wrinkle lines in the skin. And if you make an incision opposite the Langer's lines, the scar is going to spread no matter what you do.
Right.
There's so much motion of the skin that it just constantly torques on the incision and it spreads.
And then we dermatologists sometimes have to be called in to inject with corticosteroids to soften the scar tissue. And we're sometimes successful and sometimes we're not. So anything that you surgeons have come up with to minimize these large surgical scars, we're anxious to offer to people. And
Well,
that brings you to the...
that brings me to the arthroscope.
Arthroscope, right.
People have heard, I'm sure, about the use of arthroscopic surgery in treatment of knee problems. It used to be that in the knee, to have your cartilage removed, you would have to have a large incision, a great deal of downtime, 2 to 3 months to recover. And now with arthroscopic surgery, as you know, the cartilage can be removed from the knee, and the recovery is somewhere between 2 and 4 weeks, all of which time can be spent walking around and ambulating, going back to a desk job immediately and maybe a laboring job in a month. Much less downtime than before in the knee. Well, now the techniques over the last 5 years have been developed to allow us to do a great number of surgeries in the shoulder with the arthroscope. For the problem of the rotator cuff impingement, where this socket puts pressure on the tendon, the arthroscope can be inserted into the bursa. Inspection of the rotator cuff allows you to determine if the rotator cuff is torn. If the rotator cuff is not torn but pinched, and if the bursa is inflamed, another instrument can be put in from the front, observed with the arthroscope, and you can remove the bursal tissue, that inflamed tissue that's causing pain. And what causes the inflammation? It's caused by pinching of this bone called the acromion, a part of the wing bone. And so we have a little burr. Looks just like a dentist's burr,
right,
or drill. And it's used to just shave this bone into about half its normal thickness, leaving more space in the space between the ball and the socket so that the tendons are not pinched. And that relieves a great deal of the bursitis type pain. With the arthroscope then, watching this surgery being done through another hole, it allows the surgery to be done through an incision that's only 1/4 of an inch long. 1/4 of an inch to allow the arthroscope to be inserted, another 1/4 of an inch to allow an instrument to come in for surgery, and a third 1/4 of an inch incision to put some fluid into the joint so that all of the debris that's made by the surgery can be washed away.
Right.
So this problem is done for bursitis and tendinitis of rotator cuff disease. Now, another operation that can be done with the arthroscope is done inside the joint for the problem of recurrent dislocation. In the athlete who has a recurrent dislocation, sometimes the ball doesn't pop completely out of the socket. Sometimes, say in a one-arm tackle, as a football tackle sees the runner going by, he'll put his arm out. Obviously, an arm tackle is not the way to stop him, and the running back attempts to rip his arm off. And as the arm is going by, this ligament is detached. Now, the shoulder may not pop all the way out. It may begin to pop out, muscle spasm in that big tackle's arm pulls it back in, and he only partially tears this. But now, every time he raises his arm up over his head, he feels pain. The pain causes his arm to drop suddenly, and he gets a little numbness in the arm, and that's called the dead arm syndrome. Very common in football players from one-arm tackling. That's a partial dislocation. And now the arthroscope allows us to enter the joint through this thick capsule, look at the ball and socket, and see the torn ligament. Almost all of the time, that ligament is detached from the socket side. So I'll put my arthroscope in here. I'll look at the tear. Through another incision, I'll bring a staple in, and I can staple that ligament back to the bone. Now, instead of the large incision over the front, spreading all the muscles aside, doing all the damage to the tissue that you have to do, and then having to wait for it to repair for 6 weeks, now we can do this with 1/4 inch incision, We don't have to disrupt any muscular tissue, and the rehabilitation of the shoulder is much quicker. We have a tape to show what the inside of the shoulder joint looks like with this particular surgery. And if we can show that tape, I'll kind of discuss the surgery as we go along. Looking from above down in this picture, you see the ball of the ball and socket joint. And looking across the bottom from approximately 4 o'clock to 8 o'clock, you see the socket. The tissue that's being poked at with a probe is the ligament where it tore from the socket. That ligament tissue that's in the very front of the shoulder joint has a name. It's called the labrum. Labrum is Latin for lip, and it looks like a lip that has been pulled down away from the socket. And you can see the torn tissue right there. Now this is that dentist spur that is put into the joint, and now we're going to freshen the bone. We're going to grind away some of the scar tissue. Right. We're going to grind it down so that we have some fresh bone right where that burr is working. Now that fresh bone will allow us to take a staple, grab the tissue that I call the labrum, that lip tissue, grab it, here comes the staple, going to grab that tissue, and it takes a little jockeying around to make sure that you get the tissue in the right plane, get the right amount of tissue, and then take it and staple it back into the part of the bone that we just freshened. Now, this is an operation that has been done since the 1930s. It's called a Bankart repair. Dr. Bankart described it. It's the repair that is done for all shoulder dislocations. It had to be done through this big incision, and you had to partially dislocate the shoulder joint to allow it to be done. And now, as you can see with this videotape, through the arthroscope, through a couple of quarter-inch incisions, the mallet is now pounding the staple and the tissue back where it's supposed to be, into the bone.
Attached to the bone.
And now it's attached to the bone. As with, and the scope is now coming around so that we can visualize the fact that that ligamentous tissue is being stapled right into the bone. This Bankart repair, this type of repair, we know is the most important part of repairing the shoulder joint from a dislocation. If we put that tissue back, all the other things that we used to do on top of that are not nearly as important as that one single portion of the repair. The arthroscope is now just looking and probing to make sure that that's down solidly. Behind that tissue that was just stapled down, there's a little tendinous slip up there at about 11 o'clock.
Yes.
And that tendinous slip, okay, we can break from the tape now. That tendinous slip is one of those rotator cuff tendons. We can visualize all of the rotator cuff tendons through the arthroscope as we visualize the inside of the shoulder.
It's very exciting because you can absolutely have precise control of what you want to do. And as you say, you don't have to perform all these major other procedures to injure all the other muscles to get at what you really want to fix, which is that one small area. The advantages are overwhelming.
That's right, Dave. And the thing that we have to realize, however, is that on some occasions, we still need to do a more major procedure. Mm-hmm. In doing a great number of these operations where the ligamentous tissue has been pulled away and we've stapled it in, we have found that in athletes who have had multiple dislocations, where it comes out every time he raises his arm up to comb his hair, or every time a patient raises their arm up to get the cup of coffee, and that happens a lot. Or roll over in bed, put your arm behind your head, and the shoulder dislocates. That type of a chronic recurrent problem that maybe occurs 5 times a month could stretch that tissue out so badly that there's nothing left to staple. And I've seen that on occasion with the arthroscope. I've gone in, inspected, I've seen that there's nothing left to staple. There is that tendon that I pointed out in the videotape. Sometimes the staple can be used to grab a portion of that tendon and bring it back into this area. Other times the anatomy doesn't allow you to do that. In that case, I would just awaken the patient, explain to them that with the arthroscope we've been able to make the diagnosis that there's not enough tissue left to staple. And at some point in the future, after they've recovered from the arthroscopy, then we can go in with an incision and do a formal repair, as we did for many years before the arthroscope ever came about. Following this type of surgery, the patient's arm is in a sling for 4 weeks. But while it's in the sling, we let them take their arm out, dangle it, and do pendulum exercises so that the arm doesn't stiffen greatly. We just don't want, since we've stapled this and we've made this tighter in front, we don't want the patient to pull the arm away from the chest, or they'll tear the staple out. If they don't tear the staple out, they'll tear the tissue out from under the staple. So I would say that the arthroscopic surgery has allowed us now in the shoulder as well as in the knee to perform surgery for the patient without big incisions, without a tremendous amount of downtime. Even the rehabilitation with a physical therapist with this operation is much shorter than it was before. Before, with the incision, the patient would have 6 weeks in a sling, tremendous scarring. It might take 3 months to get motion back completely. And with this operation, motion can be back 2 weeks after the sling's off.
And what about pain, Vince? Besides aspirin, do they need much in the way of codeine sometimes, or heavy painkillers? Or
the roughening of the bone does cause some pain.
Sure.
And as you roughen the bone, there'll be some bleeding into the joint, and that will swell the joint, and it'll be painful. But not as painful as the big skin incision. And so, and there's no reason to put any drains in this wound. So the patient uses Darvon or maybe some codeine for a couple of days, but the need for heavy pain medication is eliminated, and they can get back to aspirin after 4 or 5 days.
It's really exciting. It's really exciting. I was thinking also the nature, let's say, of the common injuries. You know, we mentioned physical therapy. It sounds like there are a lot of approaches of just conservative therapy. I think the audience should be aware that a lot of things don't need surgery. As you've mentioned, there are conservative approaches, and that physical therapy plays a major role in the rehabilitation of a lot of these common injuries.
Dave, even in the patient with a chronic recurrent dislocation, I'll send them to a physical therapist. Strengthening of internal rotation, which is the pulling of the arm in towards the chest, and strengthening the muscles that lie in front of the shoulder joint, that by itself, even in the recurrent dislocation, that by itself may resolve the problem. If we hypertrophy this muscle, if we make it larger,
right,
then when the arm is lifted up into this position, that big muscle is pulling the shoulder in so that it can't dislocate. In the rotator cuff tear, even in the complete tear in the male over 55 or 65, the physical therapy can relieve the pain to the point where that doesn't need surgery. So I try physical therapy on everyone, explain to them that the only time that we will go to an operation is if the physical therapy fails, the pain continues, and then they need something else to control the pain.
That's excellent. Well, I thank you very much for being with me today, Vince, and I hope our audience has profited and learned a lot about these common problems in the shoulder and how physicians like Vince try conservative therapy, but if surgery is required, the arthroscope offers an exciting new means of surgery with a very small incision and a lot less recuperative time for our patients.